Good morning, students. The next topic for today's discussion is insulin therapy in gestational diabetes mellitus. What are the challenges and what are the strategies should be used? So, gestational diabetes mellitus is defined as any degree of glucose intolerance which has onset or first recognition during the pregnancy. This is regardless of any insulin use and glycemic status in the postpartum period. Similarly, it does not exclude the pre-existing unrecognized glucose intolerance, but previous history of diabetes should not be there. But if it has been unrecognized, it has not been excluded. So this is the overview of the normal pregnancy. Here we can see that during the normal pregnancy as it progresses, which has been mentioned in the orange color, and in the light pink color, the insulin resistance has been demonstrated here. So as the pregnancy progresses, the insulin resistance is usually increases during the normal pregnancy also. So from the 12 weeks onward, there is significant increase in the insulin resistance as the pregnancy progresses. But what happens in the gestational diabetes mellitus? As the diabetes progresses, the insulin output is not increased in the same manner as the insulin resistance is increased. So these patients, because of the insulin deficiency, they develop the gestational diabetes mellitus. That is the elevation of the blood glucose level, which is above the normal range. And it has to be noted that during the pregnancy, the glucose ranges are totally different from the normal population. So let's have a discussion. What is the glucose range above which we will mention that the patient is having a gestational diabetes mellitus? So underlying risk factor includes the increased maternal age, obesity, there is any history of gestational diabetes mellitus in the prior pregnancy, or if this history of gestational diabetes mellitus is not there, there is history of delivery of the large size babies. Increased risk of development of the hypertensive disorder, cesarean delivery, and development of diabetes in the later life is majority of the risk factor which has been associated with the gestational diabetes mellitus. This means that those population who have a increased risk, those who have a gestational diabetes, they have an increased risk for the hypertensive disorder during the pregnancy. There are more chances of the cesarean delivery. There is a more chances of eclampsia or preeclampsia. And similarly, those women who has a gestational diabetes, there is significant increase in the risk of future development of type 2 diabetes mellitus in the later life. Now coming to the epidemiology of the gestational diabetes mellitus, the frequency of gestational diabetes mellitus measured in 11,205 women consecutively attending the multi-resical antenatal clinic in UK, and 4% of the white population, 1.5% of the African population, and 3.5 to 7.3% of the Asian population, and 4.4% of the Indian population, and about 1 to 4% of the mixed origin women shows to have a gestational diabetes mellitus. So from here, we can see that those population who belongs to the Indian subgroup or the Asian subgroup, they have increased chances of development of gestational diabetes mellitus. The same has been demonstrated for type 2 diabetes mellitus. So the overall prevalence of the type 2 diabetes mellitus is significantly higher in the Asian and Asian Indian population, and the same thing is here is reflected in the gestational diabetes mellitus. The rate of gestational diabetes mellitus also shown to be 5 to 10 times higher in pregnant Asian than in the white women. The prevalence of gestational diabetes mellitus ultimately reflects the background rate of type 2 diabetes mellitus in the population. As we have already clearly mentioned that those population, especially Indian, they have higher chances of type 2 diabetes mellitus, and same thing is reflected in the GDM also. So GDM is more prevalent in Indian population. So this is the Indian data which has been done during the various years. So 1994, the study which was done in the Chennai, which include 950 women. So after the time of test of the GDM is 24 weeks, 3-hour OGTT was used, and overall prevalence of 0.56%. So here we can see that about 3 decades back, when the study was done, the prevalence is almost 0.56%. But the study which has been done 2008, they have shown that this is again in the same city, usually 4151 urban population, 3960 semi-urban, and 3945 in the rural population, and all trimester was included in this study, and WHO criteria for GDM was used. How increase in the prevalence of type 2 diabetes? You can see that there is the prevalence is 17.8% in overall urban population, 13.8 in the semi-urban, and in the rural population it is 9.9. So everywhere the prevalence has been significantly increased. The other areas where the prevalence has been studied in the various years, which is ranging from 3.8% to 16.5%. So overall prevalence is about 10 to 12% of the all pregnancy have developed GDM. So quite higher prevalence of this particular disorder is there, and that is why it is important to identify gestational diabetes mellitus and to treat it properly to avoid the pregnancy-induced complication in the woman and the future complication in the baby also. So Indian data, the Diabetes in Pregnancy Awareness and Prevention project, this study has been done in the Chennai city, in which the urban, semi-urban and rural population has been studied, and total of 4151, 3960 and 3945 pregnant women in the city population, and those who are in the suburban or village population has been included, and WHO criteria was used for the study of GDM. The overall prevalence of GDM is found to be 13.9% in 2009. So very high prevalence of GDM has been demonstrated in Indian population. Here the distribution among the urban, it is about 18%, it is about 14% in the semi-urban population, and 9.9% in the rural population. So significantly higher percentage of GDM has been demonstrated here. This is the age of the population which has been studied. Here we can see that various age group has been studied in the urban, semi-urban and the rural population. So almost all age group, semi-urban and urban population has a higher risk for development of the gestational diabetes mellitus as compared to the rural population. But everywhere the risk for gestational diabetes mellitus is quite high. So to prevent any complication associated with pregnancy, these women should be evaluated for gestational diabetes mellitus as soon as they came to the antenatal clinic and should be properly treated. The risk of frank diabetes mellitus following the gestational diabetes mellitus. This study, by 10 years after the parturition, has found that there is 35% of those population who have a GDM, they develop type 2 diabetes mellitus. So there is a quite high prevalence of type 2 diabetes mellitus after delivery in those patients who have a GDM. So these patients should also be evaluated at a regular interval. After the postpartum period, the OGTT should be done at a regular interval period to identify, and lifestyle modification is definitely explained to this patient to prevent the future development of type 2 diabetes mellitus. Now coming to the current recommendation for screening for gestational diabetes mellitus. So it depends on the which society we are asking. American Diabetic Association has a different screening protocol. American College of Obs and Gynae has a different protocol. WHO has another protocol. National Diabetes Data Group, United States Preventive Services Task Force, International Fraud Conference of GDN, and Diabetes in Pregnancy Study Group of India, that is a DIPSI, of Indian guidelines are different. So all these guidelines are different depending on which society you are asking. So in the nutshell, we will be discussing about the majority of the screening protocol which we should follow in our population. So screening population, according to the American College of Obstetrician and Gynecology, ADA, and Royal Australian and New Zealand College of Obstetrician and Gynecologists, recommended universal screening because of the beneficial effect from the screening and diagnosis and subsequent treatment is quite large. So we have clearly seen that the prevalence is quite high. So this particular association recommended all population should be screened because the beneficial effects of once the patient is diagnosed is quite higher. So when screening is to be done, what is the ideal time for screening? The current recommendation for screening is between 24 to 28 weeks of gestation. There are reports that claims that about 40 to 66% of the women with GDM can be detected early during the pregnancy. The ideal period for screening of GDM is around 16 weeks or even earlier in high risk group with a history of the fetal wastage. GTM diagnosis may not be missed by screening around 24 to 28 weeks, but the substantial number of the pregnant women who develop GTM in the early weeks of pregnancy are likely to delay the diagnosis and may not receive the appropriate medical clinic. So there are some of the society they recommend that as soon as possible, that is as soon as the pregnancy is confirmed, even during the first trimester, the patient or the individual, the pregnant lady should be evaluated for the GDM to have a proper benefit of early diagnosis and management. How? How we can able to diagnose the GDM. So there are again the different recommendation which society you are going to ask, whether ADA, whether DIPSI or whether ACOG. So glucose challenge test is usually the first test which is done with the 50 gram of the glucose, and the screening cutoff are usually 130 or 140 milligram. If the 130 milligram of cutoff is used, there is a 90% of sensitivity, and if the cutoff of 140 milligram is used, the sensitivity is less, that is 80% only. According to the most recent ADA and ACOG guidelines, the recommended cutoff is either 130 or 140, depending on the prevalence in the population. If it is a more prevalent, then we can take the lower cutoff definitely. For women with positive screening test, they should be subject either to the 75 gram or 100 gram of OGTT for the diagnosis of the gestational diabetes mellitus, because the screening test only picks up those population who should be subjected for the screening test. And the final diagnosis is done on the basis of the screening test, which is done either with the 100 gram OGTT or with the 75 gram of the OGTT. Now, comparison of the diagnostic threshold for the gestational diabetes mellitus. Here we can see that different diagnostic criteria has been used. According to NDDG guideline, two-step test should be done, and the glucose load is usually 100 gram, and the cutoff level is usually 105 for the fasting, 100 and 190 for the 1 hour, 165 for the 2 hour, and 145 for the 3 hour. Any two abnormal value should be taken for the diagnosis of type 2 GDM. According to the Carpenter and Cookson criteria, 100 gram OGTT should be done after the glucose challenge test, and for cutoff is fasting is 95, 180 for the 1 hour, 155 and 140 for second and 2 hour respectively, and two abnormal value are taken. For the two-step test with the 75 gram OGTT, which is recommended by the ADA criteria, is include fasting plasma glucose of 95 milligram, 1 hour postprandial, 1 hour after glucose tolerance is 180, or 2 hour is 155. Any two criteria should be used for diagnosis of GDM. According to the International Association of Diabetes and Pregnancy Study Group, 75 gram OGTT can be done directly as a one-step test, and fasting plasma glucose of 92, 1 hour of 180, and 2 hour of 153 is used as a cutoff. And one-step procedure which is recommended by WHO for 75 gram glucose, in which fasting and 2 hour glucose is done, that is fasting of more than 110 and 2 hour of more than 140. Any of one criteria usually fulfill the development of type 2 diabetes mellitus. So various criteria has been available for the diagnosis of gestational diabetes mellitus. So again, it is confusing for the student that which test has to be done. Ideally, whatever you are sticking, stick to the one test, because the diagnostic criteria has been designed on the basis of the population studies. So rather than confusing, you can follow any of the one criteria. So the most common is either ADA criteria, which include two-step procedure, or WHO criteria, which include one-step procedure, by the 75 gram of the glucose tolerance can be used for the diagnosis of GDM in our population. For diabetes in pregnancy study group of the India, this is the guideline which has been given by the Indian societies. And the pregnant woman should be subject to 75 gram oral glucose load test and at 2 hour of the venous plasma glucose, irrespective of fasting or non-fasting state, without regard to the time of the fasting with the last meal. So gestational diabetes mellitus is usually diagnosed if the 2 hour plasma glucose is more than 140 milligram per deciliter. However, the cutoff has not been put to the test to find whether there correlation with the adverse perinatal outcome. Due to high prevalence, screening is essential for the all Indian population. But the limitation of this criteria is that this cutoff has not been put for the study to find out the perinatal outcome in Indian population. So you do not have data whether it has been associated with the diabetic related complication or not. So this has a significant limitation when you are using this particular test for diagnosis of GDM. Now coming to the comparison of the various criteria, the study of 709 pregnant women to compare the anti-DG and WHO criteria. The prevalence of GDM by anti-DG and WHO criteria is ranging from 1.4 to 15.7% respectively. So you can see that there is a huge difference. So all women who are diagnosed with GDM by anti-DG criteria are also diagnosed by the WHO criteria, and there were 14 cases of macrosomia and 41 large for gestational age infant. The sensitivity of anti-DG and WHO criteria for detecting macrosomia is 21 and 42%, and sensitivity for detecting for large for gestational age is 9.8 and 41%. So women diagnosed by WHO criteria has a significantly worse outcome of pregnancy compared to the normal, including PIH, cesarean delivery, macrosomia, large for gestational age, and hypoglycemia in newborn. The Brazilian gestational diabetes study group reported 2.4 incidence 4% incidence of GDM by using ADA criteria and 7.2% incidence by using the WHO criteria in 75-gram OGTT. So by criteria, predicted increased risk of the adverse pregnancy outcome. Similarly, the WHO criteria diagnose greater percentage of women are having a GDM as compared to ADA or National Diabetes Data Group. Now coming again to the comparison of criteria on the basis of 75-gram OGTT result shows strong correlation with the macrosomia, high cesarean section and poor perinatal outcome. These findings explain the modification of ADA recommendation have been made on which now support the 75-gram glucose tolerance state, which is a threshold value of 75 180 on 155 milligram under fasting 1 and 2 hour of glucose load as an alternative to 100-gram oral glucose tolerance test for diagnosis of GDM. ADA also considered the value provided by these two methods are similar. Again, ADA two-step procedure is cumbersome. Some of the researchers reported that they follow up to 91% or 457 positive screen individuals failed to undergo diagnostic test. So significant number of the population, they failed to come for the screening test. Similarly, other study demonstrated that 23% of their screen positive women did not return for the OGTT. So universal screening test should be simple, feasible, and cost effective because we have a data that after doing the glucose challenge test, patient may not turn up for the screening test. So we should use such test which can be simple, feasible, and cost effective. So various other tests which include are fasting blood glucose or the random blood glucose tests which have become popular because they are easy to do and they do not causes major inconvenience to the patient. Unfortunately, the reproducibility, sensitivity and specificity of this test has not been proven. So currently they are not recommended for diagnosis of GDM. Coming to the role of HbA1c for diagnosis of GDM, the level of HbA1c are related to the rate of the congenital anomalies and spontaneous early abortion in pre-existing diabetes. It can differentiate between GDM and pre-existing diabetes in early pregnancy. Association between HbA1c and pregnancy outcome in GDM or prediction of macrosomia is poor. Lack of uniformity among the different laboratory has resulted in multiple threshold of normality. So HbA1c as a tool for day-to-day treatment adjustment and managing GDM is not cost effective. So at present, HbA1c should not be used for diagnosis of GDM, especially in our setting, because various method of HbA1c testing has been made available in our country. Now coming to the management of the GDM. Once the diagnosis of GDM is made, how it has to be managed? A team approach is usually ideal for managing a woman of GDM. Team should be comprised of the obstetric and gynecologist, diabetic physician, and a diabetic educator, dietitian, midwife, and pediatrician. The patient education is one of the important aspects for the management of the gestational diabetes mellitus. If the patient is not educated, then your all therapeutic option are usually best. So compliance with the treatment plan depends on the patient understanding of implication of GDM on her baby and herself, dietary and exercise recommendation to the patient, self-monitoring of blood glucose to the patient, and self-administration of insulin and adjustment of doses should be advised to the patient, identification and treatment of hypoglycemia and incorporation of safe physical activity, and development of technique to reduce the stress and cope with the denial. So patient should be educated that it is this particular disorder is going to affect their baby in an adverse way And by this, we can able to convince the patient that they now require the treatment not only for themselves, but also for the well-being of their baby. So by this, patient will be convinced and they are ready to take whatever therapeutic option you are going to give to the patient. Medical nutrition therapy is the cornerstone of the treatment of the any type of diabetes mellitus, whether it is a type 1 diabetes, whether it is a type 2 diabetes, or whether it is a gestational diabetes mellitus. Relatively little information is available to the evidence-based recommendation regarding specific nutritional approach such as total calorie and nutritional distribution. Food plan should be designed which should fulfill and minimize the nutrient requirement for the pregnancy and to achieve the glycemic goal without inducing the weight loss or excessive weight gain within the GDM mother. Adequate energy intake should be provided appropriate weight gain which is recommended during the pregnancy, and overweight and obese patient with GDM, modest energy and carbohydrate restriction should be appropriate. Ketonemia and starvation ketosis should be avoided because it has adverse outcome on the baby. Dietary references intake recommended not to increase the calorie intake during the first trimester of pregnancy, but additional 340 kilocalories should be given during the second trimester and 452 kilocalories should be given during the third trimester. This is for the those patients who are having a normal BMI. In normal weight women, recommended calorie intake is 30 kilocalorie per kilogram per day based on the present pregnancy weight. If the BMI is greater than 30 kilogram per square meter, a 33% of the calorie restriction of their estimated energy is recommended. That is approximately 25 kilocalorie per kilogram per day based on their present pregnancy weight. Another study has recommended that minimize that 700 to 1800 kilocalorie has been shown to prevent the ketosis in the GDM patient. Medical nutrition therapy should be best prescribed by a registered dietitian or a qualified individual. Food plan should be culturally appropriate and individualized. It is not possible that in the Indian population we will give the dietary plan of the foreign population, or for foreign population we will give the Indian meal pattern. So it has to be culturally appropriate. The patient should be able to accept this meal pattern. They should be adjusted amount and type of the carbohydrate to achieve the target postprandial glucose level. Institute of Medicine recommended 7 kilogram of gain in obese BMI, those who have a BMI of 30, and greater up to 18 kilogram for those patients who are underweight, those who have a BMI of less than 18.5 at the onset of pregnancy. So plotting weekly body weight is facilitated to recognize inadequate or excess of weight gain. So definitely it is important that medical nutrition therapy should be adequate to prevent any complication in the GDM patient population. Exercise should be planned. Physical activity of 30 minutes per day is recommended for all individuals who are capable of participating. Advise GDM patient to walk briskly and do the arm exercise while seated in a chair at least 14 minutes after each meal to accomplish this goal. Regular anaerobic exercise with proper warm up and cool down has shown to lower the fasting and postprandial glucose concentration in several small studies of previously sedentary individuals with GDM. Women with GDM who exercise regularly during the pregnancy, they were found to have a less likely than those who did not exercise to deliver the large size of gestational age baby. Now, after medical nutrition therapy and dietary advice, the pharmacotherapy comes. Pharmacotherapy is indicated when the medical nutrition therapy results in inadequate glucose control. Pharmacotherapy is also indicated in the setting of elevated fasting glucose level because the dietary modification has a little effect on these levels. So majority of the population, if dietary recommendation fails to achieve the good glycemic control, which is usually there in GDM population, they require pharmacotherapy. Now, what are the target glucose level in the GDM? So, according to American Diabetic Association, the fasting plasma glucose level should be maintained between the 90 to 99 milligram per deciliter. 1 hour postprandial level should be less than 140 milligram per deciliter, and 2 hour postprandial glucose level should be less than 120 to 127 milligram per deciliter. And according to American College and Obs and Gynae recommendation, fasting plasma glucose should be less than 95, 1 hour should be less than 130 to 140, and 2 hours should be less than 120. So in nutshell, the majority of recommendation that the fasting plasma glucose should be less than 99, 1 hour should be less than 140, and 2 hours should be less than 140, and the same should be followed in our population also. Indian scenario, the diabetes and pregnancy awareness prevention program, the mean plasma glucose level should be 105 to 110 milligram percent, fasting should be around 90, and 2 hours should be around 120. So this is recommended by the Indian guidelines. Criteria recommended for the initiation of the insulin. If the dietary modification fails to achieve the good glycemic control, in this scenario, what are the target level when we should start with the insulin level? If the fasting is more than 105, or fasting is more than 109, and 2 hours is more than 120, and 1 hour is more than 130, these are the recommendation for starting of the insulin level for the insulin. Majority of authorities recommend that if the fasting is more than 90, fasting plasma glucose is more than 90, we should start with the insulin. This is the exogenous insulin requirement. As we have seen in the previous slide, that as the pregnancy progresses, the insulin resistance increases in the normal pregnancy also. The same happens in the GDM. So when the insulin has been started, patient should be regularly followed up so that the insulin dose should be increased properly, and we can avoid the hyperglycemia during the pregnancy. Here we can see that during the first trimester, the insulin requirement may be zero point 0.5 to zero point 0.6 unit per kilogram of the body weight. But by the end of the third trimester, that is near the end of the pregnancy, that is up to 32 weeks, this rate may be doubled, maybe about 1 to 1.2 units per kilogram of the body weight per day. It is appropriate to use the dose needed to achieve the near normal glycemic level without undue concern about how much insulin is given. Sometimes the patient concerned that, sir, you are giving too much of insulin. So we should need to have a good glycemic control. The fasting and postprandial should be achieved in the normal range, irrespective of the level of the insulin which is required. The main concern should be the blood glucose results rather than the dose of the insulin. So this is the DIPSI guideline and recommendation of the analog. Gestational diabetes mellitus Indian guidelines. Rapid-acting insulin analog aspart, novorapid, or lispro has been found to be safe and effective in achieving the target postprandial glucose level during the pregnancy. But ideally, the human insulin should be used. But the recent guideline says this human analog insulin can also be used because they are not demonstrated to have any side effects. Coming to the long-acting analog, data currently available on Dargin in pregnancy, although not resulting from the randomized control trial, are limited observational shows that the fetal outcome are compared with the human insulin in terms of the congenital malformation. Levemir has also been approved for pregnancy by the European Medical Association, but newer insulin like degludec or U300 Glargine, which is available in the market, no data has been available with this insulin, so they have to be avoided. So insulin pump therapy and continuous subcutaneous insulin infusion, safe and reliable method for satisfying the basal insulin need in the pregnant woman with the gestational diabetes mellitus, type 2 diabetes mellitus, or type 1 diabetes mellitus. Continuous subcutaneous insulin infusion may need to be combined with CGM, and optimal glycemic control in type 1 diabetes mellitus can be used to effectively mimic the physiological insulin secretion, and there is no significant difference in glycemic control for pregnancy outcome with continuous subcutaneous insulin infusion versus multi-dose insulin. So there is no difference has been demonstrated in some of the study. So reduce the cost, we can continue with the multi-dose insulin. That is the basal bolus therapy can be continued. So no significant difference in glycemic control of pregnancy outcome with continuous subcutaneous insulin infusion on MDI therapy can help to address the delta M on nocturnal hypoglycemia or a prominent dawn phenomena. Insulin as part of Lispro are the standard of care for subcutaneous insulin infusion. The disadvantage of CSII is that complexity, which requires significant training of the patient, cost of the therapy is very high, and potential for insulin pump failure, the use of error or infusion site problem may be there. Coming to the CGMS, CGMS has become an increasing interest for the management of GDM. There are studies which has shown that the CGMS in 71%, 71 pregnant women with type 1 or type 2 diabetes mellitus allocated to antenatal care of CGMS or standard care antenatal care. Women with CGMS group has a lower mean HbA1c at 32 to 37 week compared to standard of care. So decreased mean birth weight and decreased risk of macrosomia has been demonstrated in those patients who has been treated with and benefited with the CGMS group. Similar benefit has been again demonstrated with the another study. Of sulfonylurea family, only glyburide, that is glibenclamide, has been demonstrated to have a minimal transfer across the placenta. A randomized control trial compared glyburide with the insulin in 404 women, GDM whose fasting glucose is at more than 95 milligram and 2 over postprandial glucose is more than 120 milligram. No statistically significant difference between the two groups was demonstrated for the glucose control. Lower incidence of the maternal hypoglycemia in OHA treated group and neonatal outcome including neonatal hypoglycemia, 2 or more episodes of blood glucose less than 40, birth weight, macrosomia large for gestation were not different between the two groups. So this is the only drug which can be used among the sulfonylurea, although the data is limited. Glyburide is not detectable in the umbilical cord or the blood, despite of the fact that the mother taking medication has therapeutic concentration of drug in their blood. Although study finding no difference between the two treatment group, this raised the concern whether the sample size was adequate to detect the manifold difference. And because the study population was mostly Hispanic, so generally other group cannot be used with the same medicine. So glyburide was initially demonstrated not to cross the placenta in a significant amount. This report has also noted that given the dose of glyburide resulted in a plasma concentration of mother with GDM was 50% lower than concentration in the non-pregnant women with type 2 diabetes mellitus. So the dose needed to be increased in pregnant women, although Area Society does not require the use of OHA in GDM. So MIG trial is one of the largest trial which assess the metformin in the gestational diabetes trial group, which is a large randomized control trial which is done in Australia and New Zealand. Randomized 750 women with gestational diabetes either to metformin plus insulin or insulin alone. It is a non-inferiority study. No significant increase in composite measurement of neonatal composition complication among women with assigned group of metformin has been demonstrated. 46% of the women receiving metformin also require insulin, and most women preferred metformin over the insulin treatment. Metformin crosses the placenta. Corbos is a alpha glucosidase inhibitor which is poorly absorbed from GIT, and two preliminary studies have suggested that efficacy of reducing the postprandial glucose excretion in GDM, but expected high frequency of abdominal cramp. A small proportion of this drug may cross systemically and may be found in maternal blood. So OHA and GDM, a systemic review of OHA and GDM has found no evidence of increased adverse maternal outcome or neonatal outcome with the use of glyburide, acarbose, or metformin compared with insulin. Thus, although evidence is still, they are very rare, glibenclamide and metformin seems to be safe and might be used to treat the patient with GDM. However, a sensible choice of patient who refuse the insulin, in that case, only OHA should be used. Otherwise, OHA should not be used. No organization currently recommend that any of the OHA should be used during the pregnancy. So let's convert the diabetes capital of the world into the diabetes care capital of the world with the proper management of gestational diabetes mellitus. Thank you.